section.
Good morning. Now, next section, we're going to demo for the respiratory assessment. Respiratory assessment, remember, 4 parts: inspection, auscultation, palpation, percussion. Inspection is always the first. The rest of 3 parts, you can change whatever you like. It's okay. Inspection, what do we look? We look at patient's skin color. We look at how they breathe, the breathing pattern. Okay, we will calculate the breathing rate. Okay, usually 30 seconds. We calculate how much they breathing in and out. And then we also to look have using any extra muscle to breathe. Okay, and then you will come to patient side to look their AP diameter, because if elderly people or COPD people, they will have a 1:1 to ratio. Okay, no more, it should be 2 and 1. If it's COPD or elderly people, 1, 1. Okay, and then next thing, I will use my stethoscope. My personal preference, I do listen to auscultation my second. Some people do different way. It's okay. Just remember, it's okay. It's up to you. Of course, I will check with my patient. Make sure I got the right patient. And then I will introduce who I am, what I'm doing here. I will make sure privacy, close the curtain, make sure the room temperature is okay. And because I will tell patient I need to inspect, sometimes I have to open their gums and open their gum back. We do auscultation, remember 3 areas: anterior, posterior, lateral. These 3 parts, you have to do it. During your test, you have to do it. Okay, anterior, posterior, lateral. Okay, anterior, when we do the auscultation, I always clean my stethoscope. And then your stethoscope, this one you have 2 sides, diaphragm, balsam, and you don't have to put it in your ear. Okay, you just tell us. We want the patient to help us. Okay, from you teaching them through the mouth. I do through the nose. In the nose, out your mouth. In the nose, out your mouth. Or some people ask and breathe through your mouth, in and out. Okay? If the patient only use the nose, that's not going to help you because the sound won't be clear. Okay? For anterior, just use your imagination. The lung, the right side lung has 3 lobes. The left side have the 2 lobes. Anterior, most part, up to the rib 6 is all your upper lobe. Just only little bit will be your lower lobe. So for the patient anterior, usually I do 4 pairs. Okay, you will start in the beginning. Ask the patient helping you take deep breath in your nose, out your mouth. Okay, and then you listen in the nose, out your mouth. You will compare side to side, and then up to down. Okay, take deep breath in and out, and then side to side, up and down, side to side, and coming here, and coming down here. These are 4 pairs for anterior. You listen. And then next, I will ask patient, help me open your arm. Then we will listen to the side. The very important for the right side is going to be your middle lobe. Okay, you're absolutely not going to miss that one. Okay, during the test, you have to, especially we will give you a scenario case. We will tell you patient have a pneumonia. Oh, I missed one very important thing. Before you do the assessment, you always need to ask the question. Such as like a pneumonia, I will ask them, do you cough? How much cough? You know, what can better, what can worse, and any sputum. For example, COPD, I do ask the social history. I like to know, do they smoke? Okay, what kind of job they did? Maybe they have air pollution. I know have one dealer, she has a lung cancer, not because she smoked, because the secondhand smoking in the casino. So you need to know their job. Okay, you have to ask a proper question. Okay, back to the way, listen to the lung sound, side to side, up and down. For the lateral, I do 2 pairs. is enough for me. Sometimes they do 3, depends on people's size. Okay, 2 pairs minimum to me. So when I finish the anterior lateral, and then I will ask patient turn. Or I go on the back. Same thing, I will expose the patient. Remember, we have a big 2 scalpel bone here. So I would like them help me open up here. So I will ask patient bear hug. Okay? And they will open their bone. So they will do the bear hug. Okay? Then first I do my inspection again. Look at anything I don't like it, symmetrical, or they maybe have a scoliosis, so they may have some problem. All right, same thing, I will ask patient take a deep breath in and out for me. For the posterior, I do 6 pairs, okay? You can do 5 pairs, but I do 6 pairs. And remember, posterior, you lung all the way down to T10. Okay? The posterior, only top one is upper lobe. Majority is lower lobe. So that's why you have to anterior, posterior, lateral. So does not matter which side you start. Does not matter. Okay? Right now, convenient, I will do this side. Okay, I compare, take deep breath in. You have to wait. This a lot of time we not passing you because you did not even weigh patient in and out. During the test, your instructor will demo for you. But if I not even finish, you already move. I know you did not pay attention. You gotta make sure you hear inspiration, expiration. Okay, in and out, and then you move on. And then compare upper and lower, side to side. Upper, lower, side to side. Upper, lower, side to side. Do 6 pairs. Okay, when I listen, I want to listen, is it good sound? Any abnormal sound? If I find that some sound I do not like it, I still have my stethoscope. I will continue. What that means? I can use my skill. I can use a voice sound, such as egophony, bronchophony, whisper. So we will ask you, right now, you heard the crackle. Okay, what would you do? So I will check in the egophony. I will ask the patient say E. Okay, you will do the same spot. Side to side, up and down, E, E, E all the way. If they say all E, that's mean negative. That's mean good. If the patient sound turned you know there's a trouble. Okay, that's a positive egophony. That's bad. I have a student make a mistake in the hospital. No wonder the patient is so smart. Can you say A for me? You should say E, not say A. So of course you heard the O A. Of course that's all false positive. I'm thinking, why you ask the patient say A? Well, you told me you're going to turn to the A. I said, that means the patient really going to sound to change the A. If you have a chance to listen to your pneumonia patient, really surprise you. You really going to hear A come on. Ideally, E, 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 E. But suddenly you heard A, you know something wrong. We will ask you do 2 skills. You can pick egophony, bronchophony, or bronchophony whisper, or egophony whisper. You got to give us a 2. You have to tell me the name. You have to demo your skill. Okay, you have to able to tell me what's mean positive, what's mean negative. Okay, next I'm going to do the bronchophony. Bronchophony, I will ask to say 99. Same thing, side to side, up and down. Same like auscultation. If the patient sounds getting muffled, 99, that's mean good. That's mean negative. If a bronchophony turn to clear, 99, 99, 99 all the way down, that's bad. That is positive. You don't like it. Okay, we can do whisper. 1, 2, 3. 1, 2, 3. 1, 2, 3. Should be muffled. But if getting clear, you don't like it. Anything possibly, that's mean bad. Possible consolidation, possible hemothorax, possible peripheral infusion, possible tumor. All the possible. okay?